everybody. I am so excited to be here. I thank the organizers for allowing me to participate and share with you today. I want to be sharing on a time to focus on what matters most, utilizing CGRP targeting monoclonal antibodies for prevention. My disclosures have been are there, and I therefore anyone that needs to know. So we're going to jump into these learning objectives. So we're going to recognize and the negative impact of migraine misdiagnosis and mismanagement and what that places on patients, as well as evaluate limitations of standard treatment and options and clinical care for the prevention of migraine. And we should be able to apply, by the end of this, apply the efficacy, safety, and long-term data of CGRP monoclonal antibodies, or MABs, for the successful treatment of migraine. So let's listen to Laura.
Hi, I'm Laura, and I really need some help with my headaches. I've always had a battle with headaches, or at least after I started my periods. When I was a teenager, I had these really difficult headaches that would begin about a day before I started to flow, like clockwork. So extra, right? Well, I learned to cope with those using naproxen over the counter, and things gradually got better as I got older. In my 20s, I was diagnosed with major depression plus anxiety. This began with postpartum mood stuff after my second baby. The OBGYN put me on sertraline for that, and it's worked pretty well. I mean, I'm still on it, but I don't have to do therapy anymore. The problem now is that my headaches have just gotten out of control. I mean, like crazy. At least once a week, I have a headache that lasts 2 to 3 days. It comes out of the blue, and it's just this intense throbbing. I get sick to my stomach. I have to go lie down in a dark room and keep things as quiet as possible. I know, totally impossible with a toddler and an 8-year-old. I take a tablet with aspirin, acetaminophen, and caffeine in it, anywhere from 2 to 6 times a day. My OBGYN recommended those. And overall, I probably need those about half the days in the month, but it's escalating, like big time. My primary nurse practitioner started me on amitriptyline, but that just made me feel super tired in the morning, and I couldn't take care of my kids. I then tried propranolol, but that made me dizzy every time I stood up. We then switched to topiramate, but that made me feel bad, and the nurse practitioner said it was messing with my blood work somehow. I'm really scared, and not just because of the pain, but I'm losing the ability to take care of my kids properly, and I feel like a complete failure as a mom. I've been missing a lot of work, and HR says if I don't do something fast, I'm gonna have to apply for disability. That seems totally wrong. I mean, I'm in my 30s, not my 60s. You're kind of my last hope here. I've just about lost my mind thinking about how I need to get better soon. I was really hoping for something I can just take every now and then that would help me. I'd even be willing to take a shot if I need to.
So unfortunately, that's not an uncommon experience that people with migraine have that come and see headache specialists. So what I want to do is talk about some of the problems with diagnosis, impact, prevention, and management, and for patients with migraine. Now, this was done over 15 years ago that looked at the prevalence and diagnosis of migraine and patients that were consulting with their physician. And overall, what we saw was patients that saw a physician for a non-migraine primary headache disorder or a new diagnosis of migraine, 98% of these patients, 98% of these diagnoses, if it was diagnosed migraine, had the chance of having the correct diagnosis. If it was a non-migraine diagnosis, it was an 82 chance of an incorrect diagnosis. So this may be very kind of foundational for people, but I just want to go and share briefly on what is the diagnostic criteria for migraine. So you need 5 headache attacks. Remember, migraine is a syndrome. You need 5 headache attacks that last 4 to 72 hours untreated or unsuccessfully treated. And it has the headache has the following characteristics, at least 2 or more: unilateral, pulsating, moderate, or severe. And sometimes I have to tell patients that even if you just have a moderate headache, or if it is a moderate headache, that could be migraine as well, because a lot of people say their most severe is migraine. But by criteria, but both moderate and severe pain intensity, and aggravation or causing avoidance of physical activity. During the headache, you need one or more of the following: nausea, vomiting, photophobia, or phonophobia, not attributable to no other disorder. And so what's migraine? That was migraine without aura. So what is migraine with aura? Well, you need at least 2 attacks of aura with one or more of the following reversible oral symptoms: visual, sensory, speech, or language, motor, brainstem, retinal, and at least 3 of the following where either the oral symptom develops gradually over 5 minutes. It may last 5 to 6. Each system, individual symptom can last 5 to 60 minutes. 2 or more symptoms occur in succession. One, the aura is unilateral. At least one of them are positive, and the aura can be accompanied by or follow within 60 minutes by a headache disorder. So I'm going to jump because there's unmet needs and barriers to care. And this was Dodick and all that looked at those, and this is actually chronic migraine, and I will tie this all in just a few moments. So among those who consulting with a healthcare professional, which is only 40% with this, only about a quarter received an accurate diagnosis. And where they looked at these 3 different barriers, only 5% of patients with chronic migraine traverse all 3 barriers of medical consultation, accurate diagnosis, and minimum pharmacological treatment. And so what we know is that compared with episodic migraine, that patients with chronic migraine have a greater impact on activities of daily living, medical costs, healthcare utilization, higher rates of comorbidities, and reduced quality of life. Just a few weeks ago, there was a presentation, the Wolf Award winner, where Dr. Shi and colleagues looked at chronic versus episodic migraine. So we're looking now at this 15-day threshold where it does not adequately reflect substantial differences in disability across the full spectrum of headache frequency disorder. So what we have here, so I talked about episodic migraine, I talked about chronic migraine, but there could be low frequency episodic migraine and high frequency episodic migraine. And high frequency episodic, what they found, this group found, is that high episodic frequency migraine is just as debilitating as some with chronic migraine. So the use of the 15-day headache day per month threshold to the episodic and chronic migraine does not capture the burden of illness nor reflects the treatment of needs in its patients. And in this study, they have 4 different groups. The high frequency episodic migraine had 8 to 14 headache days. And then there was a chronic migraine group that had 15 to 23 days. And what we saw was there was no statistically significant differences in a lot of the patient reported outcomes in that study. So there can also be a roller coaster of episodic migraine and chronic migraine. This is by Serrano and Lipton and colleagues as well, where you see this fluctuation with monthly headache frequency. And the challenge with that is that migraine, if you look all the way toward the right, where you can call it the arrow sign, I'll have a few of those throughout this presentation. As far as the age standardized years lived with disability, migraine is very, very much up there. In fact, migraine is the leading cause of years lived with disability, as indicated by Steiner and all here, of people under the age of 50. So we're talking about a very disabling disorder, and talking about this progression. And what I'm trying to get to here is that there are treatment needs, there are treatment gaps for patients with high frequency episodic migraine. It's been shown that there's new incidence of chronic migraine, annual incidence is 2.5 in episodic migraine patients, but patients can move back and forth. But then there's this group, again, this high frequency episodic migraine. This definition in this particular study, they used 10 days to 14 days for pain per month. In the Wolf Award study, they used 8 days. So we know with 8 days is about the threshold. And you can get moving, going back and forth, but I just kind of explained how disabling these higher frequency of episodic migraine attacks and people with the migraine can be. You also have chronic medication overuse headache, right? Medication overuse headache is second highest risk factors for developing chronic headaches, and it kind of gets this transformation for from episodic migraine to chronic migraine. So again, there's this fluctuation going back and forth, and we just have a treatment gap for patients particularly with high frequency episodic migraine. Now, all of this newer evidence has actually led to a proposed new criteria for chronic migraine. So if we look at the what we have on ICHD-3 currently right now, the chronic migraine is 15 headache days or more for 3 months. Have to have those migraine attacks that I talked about in episodic migraine, and then greater than 8 days per month with basically a migrainous attack or headache attack or something thought to be migrainous. Then you have medication overuse headache, which occurs in patients with a pre-existing headache disorders. And again, headache is over 15 days per month. And there's regular use of one or more drugs or treatments, acute and or symptomatic treatment or abortive treatments for 3 months. And there's specific criteria for that. So what I want to show again is that even these high frequency episodic migraines kind of make us think about, because of some of the different gaps and the treatment gaps, that make us think about this new criteria where they're looking at 8 days or more per month now. So speaking of treatments, let's talk about what we've had before the monoclonal antibodies and what we still have obviously in practice today. So there's different levels of evidence and efficacy. Level A, you have your anti-epileptic drugs, your beta blockers, angiotensin receptor blockers is now, it used to be a lower level, but now there's evidence to suggest that this is also level A now. And you may have heard Laura talk about some of these treatments that she actually had, the propranolol and topiramate, and she also talked about having the amitriptyline, which is actually level B. So level B, you're going to have some more antidepressants and some different types of beta blockers. And level C, ACE inhibitor, different types of beta blockers, alpha antagonists, anti-epileptic drugs, and antihistamines as well that are possibly effective. The only FDA-approved treatment for chronic migraine prior to 2018 was unobotulinum toxin type A. And this was approved in 2010. FDA approved 2010, and it was the only one up until 2012. Now, the challenge that we have with some of the oral preventions, first of all, they're not migraine specific, right? And so, there also is a terrible inherent adherence to this. So over a year's period of time, in a study that was done, patients either whether due to lack of efficacy or medication side effects being the most common, only 17% of patients were still on the preventive meds. 17% of patients. If you back that up 6 months, it's just over a quarter of patients. So 83% of people with migraine discontinued their preventive treatment over a year. And when we look at the ATTAIN study, and this looks more at the 6-month prospective study, you see about half of patients, there's 234 patients in this study, about half of the patients had one or more modifications with taking their migraine prevention without consulting their provider. Right? So they're doing this on their own. So there's 312 modifications over a 6-month period of time. Over a quarter stopped due to decreased frequency in the dose. Over a quarter stopped because of the medication. Stopped the medication. Over a quarter, decreased the frequency or dose. Excuse me, I misspoke. And over a quarter delayed dosing by a day or more, and then over 15% increased the frequency of the dose. So at least 2/3 made these modifications due to adverse effects or ineffectiveness. So again, approximately half of the patients in the study altered their preventive medication without supervision or consultation due to the lack of efficacy and generally due to lack of efficacy and adverse events. And this suggests that there is limited therapeutic value of non-specific medication for traditional migraine prevention. Also, this self-adjustment of these medications poses a potential serious risk of like withdrawals, whether it's withdrawals, seizures from discontinuation discontinuation of anti-epileptic drugs or arrhythmia from acutely stopping beta blockers. So this is a challenge, right? And so the consequences, as we saw with these challenges, is that the absence of migraine-specific medication led to 83% of patients discontinue their medication within a year. The World Health Organization has shown that migraine is the top 5 disorders, right? One of the top 5 disorders, right? This is due to lack of migraine-specific prevention, in part due to lack of migraine-specific prevention. That track record of 17% adherence to treatment is an example of clinical futility, right? I mean, with severe medical, social, economic costs for patients across studies and across the society. And even though botulinum toxin type A has better adherence, it's only indicated for that chronic migraine. So what happened with those people? Again, now you're seeing where I'm tying in those treatment gaps with patients with high episodic, high frequency episodic migraine. So, but all patients really need to be treated. So the advent of migraine-specific treatment. So when we look at this particular treatment target and the topic of this conversation is the CGRP. When we look at the CGRP, so how does migraine-specific treatment work? So triptans and ergot prevents CGRP release, right? And we're kind of looking at the pathophysiology of migraine, right? Lasmiditan prevents CGRP release, right? Botulinum toxin A prevents CGRP release as well. The anti-CGRP receptor monoclonal antibody erinumab it actually blocks the receptor. Then you have the anti-CGRP ligand monoclonal antibodies. That's the eptinezumab, fremonezumab, and galcanezumab. And then there are also CGRP receptor antagonists, or these are the GPANs. And rimagepant and ubrogepant are FDA approved. Atogepant, I believe, has gone in for the FDA, but atogepant is zavegepant is investigational right now. And so triptans and ergots constrict CGRP dilated vessels, right? CGRP is important for the dilatation of blood vessels. It's ubiquitous peptide throughout the body. And then neural inflammation may be modulated by the non-steroidal anti-inflammatory. So these are kind of this migraine-specific treatment of target, right? And so let's talk about the monoclonal antibodies. Well, hats off and major congratulations for Dr. Sinzu, who is the inventor of erinumab here. So the monoclonal antibodies are large molecules that do not pass into the brain. They're removed by the reticuloendothelial system. So there's no liver toxicity of some of the things we may have seen, we did see with the earlier trials of the actual GPANs, earlier GPANs, should I say. And they work peripherally to prevent a migraine. And you can see the size difference between the GPANs and the anti-CGRP monoclonal antibodies as demonstrated there in their relative size. There are 4 monoclonal antibodies. Erinumab was FDA approved for a migraine in May of 2018. It's against the receptor, the CGRP receptor, and is a monthly subcutaneous injection. Fremonezumab was FDA approved in September of 2018, antibody against the CGRP ligand on the peptide. And this can be done as a subcutaneous monthly injection or quarterly injection. Galcanezumab was approved for migraine a little less than 2 weeks after the fremonezumab. And this has also been approved for episodic cluster, and that was in 2019. This is an antibody against the CGRP peptide, and then it's a subcutaneous and monthly injection as well for migraine. And the eptinezumab was the most recent one that was approved, which was back in February 2020. This is an antibody against the CGRP ligand, and it's administered intravenously on a quarterly basis. So again, so this is how they're giving erinumab, galcanezumab, self-inject monthly, with galcanezumab having a loading dose for the first month. Fremonezumab is self-inject monthly or every 3 months, so patients can essentially get away with or just only have to have 4 for treatments in a year's time. Same thing with eptinezumab, except for this is given in the IV infusion every 3 months as well. So major questions of monoclonal antibodies: are they safe? Are they different from traditional treatments? Are they an improvement in terms of addressing patient needs gaps? So let's talk about the safety. When we look at the safety, the liver function abnormalities have not been seen in excess to placebo. Upper respiratory infection is not with every product and not always in excess of placebo. Constipation, so the erenumab does have, in the US, has a constipation warning and is noted for galcanezumab in the EU. And then hypertension we've seen in post-marketing studies or observation with erenumab, and so that's included in the prescribing information as well. And as you can see, the injectables had injection site reactions. The IV eptinezumab had URI, dizziness, and nausea, but these were also seen in placebo as well. And so the question is, because CGRP is so ubiquitous, will losing CGRP or its receptor result in a loss of compensatory vasodilation or hemostatic vascular protective mechanisms necessary to prevent stroke or infarction in the setting of ischemia? Well, in this double-blinded placebo-controlled study of 88 patients where intravenous erenumab was used, it did not make angina worse. So there was no difference in the change of baseline for exercise duration, time to onset of greater than 1 millimeter ST segment depression, time to onset of exercise-induced angina during a treadmill exercise test. So there's no infarctions, no evidence for failure of compensatory mechanisms. And so there were no vascular signals seen in 3 to 5 year data for all three. However, with any new class of medication, clinical vigilance is very, very important. So let's discuss a little bit of the pivotal trials or endpoints. And as you see in the episodic migraine, so we're going to start episodic migraine in the 3 randomized controlled trials. You can see erenumab at a dose of 70 milligrams to 100 and 140 milligrams met its endpoint in statistically significant from placebo. Galcanezumab at the 120 milligram dose and 240 milligram dose separated from placebo as well. The fremanezumab, whether it's the quarterly dosing or the monthly dosing, also met its primary endpoint separating from placebo. And in the IV eptinezumab at 100 milligrams and 300 milligrams also met its primary endpoint. So now let's look at chronic migraine. And this was a reduction of monthly migraine days from a baseline of 16 to 18 migraine days per month. And you can see that in all of these studies, all of these treatments, there is a separation from a statistically significant separation of from placebo in erenumab, fremanezumab, HALO study, galcanezumab, REGAIN study, and eptinezumab in the PROMISE 2 study. And so what I've done is what we have here is essentially the phase 3 trials, and this is with the CGRP monoclonal antibodies or the receptor antibody at the most effective dose versus placebo. And what we just see is that they're all statistically significant. So let's look at a couple of secondary endpoints and responder rates. So what we're starting to see with this, remember this is migraine specific, we're starting to see unprecedented 75% and 100% responder rates. So this was galcanezumab and episodic migraine. And you can see over the month on the left-hand side of the slide, that's the percentage of patients with 100% response. And then on the right-hand side of the slide, some patients with the 75 or greater 75% response. And you see that over all months here, 1, 2, 3, and 1 through 6, that there is a difference, a separation from placebo. And we saw placebo-controlled data, eptinezumab at 300 milligrams, 70% can reach a 50% responder rate for episodic migraine, and 54 had greater than or equal to 75% reduction by 1 year. So, and this was in the episodic migraine. And so this is, again, unprecedented. Let's continue with some things that are unprecedented. How about how fast the onset could happen and does happen with the monoclonal antibodies, where they separate from placebo? We can see that in these pivotal trials that there's separation in about a week. Okay, separation about a week. You have erinumab subcutaneous there. You can see at week 1. You see it both at week 1 and for chronic migraine and episodic migraine that there's separation from a placebo. Fremanezumab showed improvement in migraine pain and all migraine-associated symptoms of nausea, photophobia, and phonophobia in less than a week. And eptinezumab showed a difference actually within about a day. So there was a 50% drop in the likelihood of a migraine within day 1 of infusion of eptinezumab with both of the 100 milligram and the 300 milligram doses. So we're seeing this. Now let's talk about the monoclonal antibodies in those with the lack of response to multiple previous preventive treatments. And the time may be a little bit blurred, but hopefully you can see that even in this erinumab, whether in fremanezumab and galcanezumab studies, you see that there are differences in placebo, and these mAbs work in the target patients, those with lack of previous response to multiple preventive agents. How about medication overuse, right? The conversion, whether a medication overuse to non-medication overuse. We know, again, that it's a risk factor to disease progression, but in both episodic and chronic migraine. And you see with erinumab that there's conversion to non-medication overuse headache. And then we see this also with galcanezumab, where there's also conversion from episodic migraine plus medication overuse and chronic migraine plus medication overuse to non-medication overuse. So do GPANTs work acutely in patients with monoclonal antibodies? Well, so far, short answer, yes. And so as they are effective, safe, well tolerated. There have been a few studies, case reports. There was 13 patients on erinumab, fremanezumab, or galcanezumab treated with migraine headache, who treated their migraine headache attack acutely with rimegepant 75 milligram. All of them responded. One of the patients had first-degree heart block. One had dizziness. Both of these were considered possibly related, but no other treatment emergent adverse effects, adverse events, excuse me. And 40 patients, and another 40 patients were given erinumab or galcanezumab and ubrogepant daily for 4 days and crossed over to a monoclonal antibody alone versus ubrogepant alone. And the treatment-related AEs appeared only in the mAb group, and there was no clinically relevant changes that was noted in labs, vital signs, or EKG. So are mAbs superior to previous migraine populations? And so let's compare some of these with the placebo-extracted analysis. Before we get into that, let's learn or relearn or refresh our memory on some of these terms. Kind of took me back to a lot of my different studies, but I think this is important to understand. So the therapeutic gain is the difference between the active response and the placebo response. 1 over the therapeutic gain is the number needed to treat. And so for the number needed to treat, the lower the value, the better. Similarly, therapeutic harm is the active adverse events difference between that and placebo. The number needed to harm is 1 over the therapeutic harm. However, for number needed to harm, the higher the value, the better, right? We want way more patients to be able to take this before it harms anybody, okay? Things like that. And there's a number needed to harm over the number needed to treat is likelihood of being helped or harmed. The higher the value, the better. And so for the NNH over number needed to treat, this or the LLH ratio describes the value of an intervention as a risk-benefit analysis number. So let's look at that in chronic migraine and episodic migraine with some of these therapies. So erinumab, you have the doses of 70 and 140 milligrams here. And if you go down to the highlighted, down at the bottom, you see that the number needed to, the harm over the number needed to treat is higher in the erinumab than it is in the topiramate, also higher also higher in unobotulinum toxin type A there. And so you can see those, hopefully you can see those numbers there. And then in the episodic migraine, when we're looking at erinumab versus topiramate and propranolol, remember that unobotulinum toxin is approved for FDA approved for chronic migraine, so it's not included in this. You can see similar results where the adverse event profile of the mAbs really overwhelms the traditional medication, where this LLH for erinumab is 167 versus 2 for both topiramate and propranolol. So a few more definitions. The number needed to treat for 50% response rate, so that's NNT 50, the lower the better. The number needed to treat before seeing a serious adverse event, the higher the better. So that's the NNH SAE, and then the NNH AE. That's the number of patients that need to be treated for a patient to experience adverse events that will lead to treatment discontinuation. So that's that D there. So the higher, the better. Again, we want more patients to be able to take and tolerate the medications or the treatments or what have you before somebody felt like they have to discontinue due to an adverse event. And what you see is just here, this is just remarkable differences in the NNH SAE and NNH AE. And so this is erinumab here with 283. I won't do this. You can read and hopefully see the numbers there. But I will point out when we look at these is like the magnitude difference of topiramate, right? I mean, and propranolol, 100 milligrams of topiramate, 160 milligrams of propranolol. So, I mean, the order of magnitude is totally is really significant, as you can see there. And then this is additional studies here looking at the NNH SAE and NNH AE. And again, I mean, these are on the order of 1,000 at least for the eptinezumab, gacanezumab, and in the tens basically with fremanezumab, and the eptinezumab 300 milligrams. But you can see that in comparison to the unobotulinum toxin type A and topiramate 100 milligrams. And this was the Unibot at 155 milligrams. I mean, 155 units, I'm sorry. So in conclusion, after all that, the higher number of patients treated, there's much higher number of patients treated who are needed before seeing adverse events, which overwhelmingly favors the mAbs over ordered treatment. These placebo subtracted analysis suggests superiority, right, over traditional treatments and suggests treatment paradigm shift. The anti-CGRP monoclonal antibodies as a class treatment really perform better in all of the 3 benefit risk assessments versus standard anti-migraine treatments. And next, I wanted to show that was recently distributed and shared that the first phase 4 randomized double-blind, double-dummy, head-to-head study of erinumab against topiramate, and this was the Hermes study. And this study, these were patients with episodic and chronic migraine, met all its primary and secondary endpoints. And these results showed that erinumab had a superior tolerability and efficacy profile than topiramate, with less discontinuation over the 24-week period of time. So, and that erinumab was also superior in efficacy with a greater proportion of patients receiving or achieving, should I say, greater than at least a 50% reduction in their mean monthly migraine days. And so, so that's a direct comparison. How about another common question? How about onabotulinum type A and the mAbs. Well, just a little bit of background, onabotulinum type A inhibits the release of CGRP, which I talked about in an earlier slide, and inhibits unmyelinated C fibers and inhibits wide dynamic range neurons in the spinal trigeminal nucleus. Fremanezumab targets the CGRP ligand. Atogepant blocks the CGRP receptor. Fremanezumab and atogepant both inhibit thinly myelinated A delta fibers and inhibit high threshold neurons in the spinal trigeminal nucleus. And so when Unabot and atogepant were administered simultaneously, they reduce CGRP activity by different mechanisms and inhibit both the C and the A delta fibers and both wide dynamic neurons and high threshold neurons. And so a few retrospective studies essentially will show that demonstrated that there was an increase in potentially synergistic when you had the combination of that. So the Georgetown study had Unabot, where you can see there's a reduction in 11.3 versus combination of Unabot and Numab, 14.9. I'm not going to read the slide to you. I just want to show that we can see that there's significant and additional reduction in mean monthly migraine days when you have this combination. And even the Blumenfeld retrospective study, where it was 257 patients with a baseline of 21.5 mean reduction, 21.5 migraine days, monthly migraine days, over 12 months, this combination allowed them to get over half of their headache mean migraine days decrease. So let's go back to Laura. We talked to her, got her some great therapy, some of the things I've talked about, and so let's see what how she's doing.
So this cool auto injector thingy is working really well for me. I appreciate your nurse taking the time to show me how to do it. Injecting myself in the office the first time allowed me to have the confidence that I could do it on my own. I can't believe the difference. I mean, for the past 6 months, it's just been a game changer. I could tell in the first month that the headaches were less frequent and less intense. They also didn't last as long. I'm down to headaches now that last less than a whole day. Sometimes they're mild enough that acetaminophen alone will work for me, and I usually don't have to take those more than 2 to 3 days per month. I haven't had to take sumatriptan for rescue in months. Last month, my boyfriend and I had a celebration dinner when I was able to mark off 30 straight days without a headache. Of course, 2 Pinot Noirs meant that I had a headache the next day. Lesson learned, right? The treatment's like way easy. I just auto-inject in each thigh and in my belly, and it gets a little red for a day or so afterwards, but nothing too bad. I can't believe I only have to do it 4 times a year. I feel like I have my life back. I'm a good mom again, I'm a fun girlfriend, and I go days without thinking about headaches. Migraines aren't running my life anymore. I am.
So that's awesome. That is awesome. And that's where we want people to go. So let's, to summarize, well, who's first should receive these new preventive treatments? Well, the AHS has put together a position or consensus statement in 2019. So these should be available to be prescribed by any licensed healthcare provider to patients who meet the following criteria. So if you have lower frequency episodic migraine, you need lack of success with 2 different therapies, whether they be the anti-epileptic drugs, tricyclic antidepressants, beta blockers, SNRIs or serotonin norepinephrine reuptake inhibitors, or other level A or B preventive medications. And there has to be a documentation of at least moderate disability or impact from the migraine. For a high frequency episodic migraine, same requirements as before, but there's no need to document disability as they are clearly impacted, as hopefully I have shared and everyone understands at this time. And then for chronic migraine, similarly, except for you can add unobotulinum toxin type A as an additional choice. And then again, there's no need for documentation of disability as they are clearly impacted. So two concluding slides on the paradigm shifts of migraine treatment 2021. Traditional prevention is continued by 17% of patients across the year. The monoclonal antibodies are superior to traditional treatments when efficacy and AEs are evaluated. The erinumab is superior to pyramid was studied head-to-head, right, for adherence, efficacy, and tolerability. The monoclonal antibodies work well in target populations who have the treatments have failed them, right? And monoclonal antibodies generally convert the majority of people with patients with medication overuse headache to non-medication overuse headache with no further intervention. MABs have a remarkably fast onset and as seen in some of the RCTs, the MABs are unprecedented high response rate and GPANs work well acutely with the MABs. MABs and Unobot treatments may be synergistic. And stratified care, we've been saying this for a long time, where we match the patient's needs to the treatment choices is likely to result in a greater likelihood of optimal outcomes for patients rather than stepping through to traditional treatments. And so I like this quote here by Dr. David Dodick, who says, "I see a day within our careers when it will not be acceptable to treat patients by having them cycle through a ragtag group of drugs that over 80% will stop within a year just to get to disease-specific and mechanism-based treatments that were specifically designed to treat this disease." And with that, I want to thank you for your attention and welcome questions. Thank you so much.
That was terrific. Thank you so much, Dr. Charleston, and welcome everyone to the live Q&A. Before we begin, I would like to recognize that this session is supported by independent educational grants from Amgen and Teva Pharmaceuticals. And now we will open it up. We have several questions that have been submitted. I'm going to read the first one now. It was interesting to learn about the low diagnostic rates of migraine disorders. Any thoughts on strategies to increase migraine diagnosis? Very important question.
Yeah, so thanks, guys. I think that's a great question. I was shocked to learn some of the data as well, but I do know that even in medical schools, that a lot of medical training only get 3 hours. So we need to start at medical school. I think there needs to be a public awareness as well. I think there has been stigma behind migraine that I think that we need to better erase, and that we need to reframe migraine. And I think that it needs to be supported. I also believe that with some of these newer treatments that are coming back, and you're looking, and I showed the diagram of the pathophysiology and everything, and so you're looking at some of the pathophysiology, people's like, okay, it's not just in someone's head, right? It's not that. So I think that as we continue our research, that we kind of add value to the field, and what we definitely need. Even getting a lot of our primary care specialists, practitioners, they cover so much, but if we can find ways to really help and support them and get them the right treatments and also education and knowledge and things like that, I think that would be great. And we need it in neurology as well.
100% agree. Our next question is one that I get not too uncommonly. Over time, does the body adjust to the medication such that its effectiveness plateaus?
So I think that's a very interesting question. I'm actually not aware. I mean, I'm assuming when you say medication, we're talking about the monoclonal antibodies, right? And so in that case, I'm not exactly sure of any evidence that actually shows this. I mean, could the body start doing some upregulation? Because this is a ubiquitous, the CGRP is a ubiquitous protein all over. Are there mechanisms? I don't know if we actually know that, or at least I'm not sure of that. Theoretically, I don't think that the monoclonal antibodies block every CGRP, right? I mean, every CGRP molecule or every CGRP receptor. I think it probably blocks a lot of them. I would guess maybe 70, 80% of them, maybe. So there always probably be some CGRP that may be left over that may be able to be activated. And then also, I didn't talk about, but with the CGRP, I mean, the whole calcitonin receptor and everything. I mean, there's an amylin part too. So what part does amylin actually play in this role? So I think it's a little bit probably more complex than just simply straightforward, because we know that amylin, the amylin receptor, there's I think it's about 100% to 100. I don't want to get the numbers wrong, but we know that there are some. There's an affinity for the amylin as well, right? It's a little lesser for even for the CGRP receptor. It's a lot lesser, but there is an affinity there. So how does all interplay? I think is a very, very interesting question, and I'm not sure if I have the right answer for that, but just kind of thinking through it through a pathophysiology type of state, that might be one.
Yeah, I certainly don't have a clear answer either. Oh, go ahead.
One other thing too, if this is happening and patients are starting to become, are starting to have increased headache days where they're doing well, things like that, I think it's always important to kind of look at other things, other factors that's happening as well, because it may not necessarily be just the medication. Maybe there's a little bit more stress. Maybe they're not, they're very busy and they're not drinking like they should, or like just anything. We all go through life. So I think just kind of looking at the person as a person and say, okay, we notice this, but kind of look at some of these other aspects that happens to us all in life. There was up studying for an exam, right? Or they just in a busy season in their life, or what have you, or they not exercising like they used to, or so many different things can happen. That exercise like you used to is kind of something like this is one of those things like that. But anyway, so I think that's something that we could think about as well.
Yes, absolutely. I know we're technically over time, but I'm going to take the moderator's prerogative, and because we got a lot of great questions, we're going to do just a couple more. The next one is about streamlining the traditional drug pathway before attempting insurance coverage for the CGRP inhibitors. What can we do for that?
Yeah, so I think that's a great question. Hopefully some of that was answered right at the end, right? So right at the end where we looked at, and even since I recorded that, there was a more recent AHS consensus that came out in June. I mean, it's very similar. I didn't see that many differences. I think they included more some of the modulation as well with that, but the neuromodulation devices and things. But kind of looking at those level A and level B. I mean, because there are a point where people are just not getting the right meds. I actually published a couple years back when it's actually you don't know, but I'm looking at it. It was like, do disparities exist in ambulatory treatments? Well, what we were looking at is what people were getting and seeing if there was a disparity. We just noticed that a lot of people are not getting the things that they should be getting. It didn't matter what their race or ethnicity was. So it's actually kind of embedded in there. I actually have tables in there that actually look at that question too. So, but kind of following these guys, their guidelines, right? So I, consensus statement type of guidelines type of thing, following those things where we can give people high evidence things if we have to kind of go through payers. I don't particularly like that, but I know that's what we have to do sometimes. But kind of following those AHS guidelines might be helpful with that.